Honorable Chairperson, respected panelists, and my dear audience, very good morning. I am very blessed that today my mentor, Professor Sufia Rahman, is on the dais. Today my talk about the transcatheter aortic valve replacement versus surgical aortic valve replacement current and emergent concept. We everybody know surgical aortic valve replacement is the oldest and still the acceptable therapy for severe aortic stenosis in some cases. But transcatheter aortic valve replacement is the non-surgical, interventional, modern, low-risk procedure for severe aortic stenosis in most of the cases. This is the prevalence of the aortic stenosis in the US. About the 7% population more than 65 years of age having the aortic stenosis. This is one of the Indian study. It shows 0.2% the patient between the 50 to 60 years having the aortic stenosis. Even the 9.8% population more than 80 years of age having the aortic stenosis. And very interesting finding is in our subcontinent, the 25 to 40% Asian population have the bicuspid aortic valve, unlike the Western. We know the causes. Most common cause is the degenerative, the intermediate is rheumatic, and less common is congenital, especially bicuspid aortic valve. These are three major causes. This is the normal, this is the bicuspid aortic valve, this is the degenerative, and this is the rheumatic. We know the symptoms, the heart failure, angina, and syncope of symptomatic severe aortic stenosis. And this is very important slide that when the symptom of severe aortic stenosis happen, the life expectancy is dramatically reduced. Even the patient who develop the angina, he have only 5 years survival. The patient develops syncope, only the 3 years survival. And the patient develops left ventricular failure, only 2 years survival. This is one of the another interesting slide which shows that the 5-year survival in breast cancer, lung cancer, colorectal cancer, prostate cancer, and ovarian cancer. Even the lung cancer has the 4% survival rate, but the severe inoperable aortic stenosis only 3% survival rate in 5 years. This is our echocardiography criteria. This is the recommendations. There are 3 types of procedure for aortic valve replacement. It is transcatheter aortic valve replacement, surgical aortic valve replacement, and minimum incision valve surgery. Very interesting is about the 40% of the severe aortic stenosis is not treated by the surgical aortic valve replacement because most of the patient is a high risk. They don't go for the surgical aortic valve replacement. This is the history of the TAVR. In 2002, 16 April, Professor Alan Kibria first implanted the valve in France. And this is the world scenario. Is the spectacular worldwide expansion. Is a 4-fold growth within 10 years. Hopefully in 2022, there will be 20 lakh implantation throughout the world. This is what is the evidence? Just see, the partner 1B and core valve ER shows TAVI is superior to the medical treatment. Then the partner 1A and core valve HR shows TAVI is non-inferior or superior to surgical aortic valve replacement. The partner 2A and SAR-TAVI shows that TAVI is non-inferior, even superior to the surgical aortic valve replacement in transfemoral access. In 2019, the largest study shows TAVI is superior to the surgical aortic valve replacement. These are the devices, especially the more devices coming, two type of devices there in the market. It is all of the balloon expandable. These are the self expandable. This is the other design. What the technology is improving in 2002 and 4, only the Crib-Edward valve, it is compassionate. Then 2005 to 2010, it is only indicated as the inoperable and high risk cases. 2010 to 2018, it is done in the inoperable, high risk and intermediate cases of the patient. 2019 is declared TAVR can be used in inoperable, high risk, intermediate, even in low risk cases. This is one of the promising valve, new valve is made in India, is my valve, is from the Merrill Science. It is the highest number of valve implanted in this region. This is the new valve from the Boston Scientific, from the Abbott and the other companies, and the new delivery system is coming up. This is the study, the TAVR and SAVR in low risk patient. It shows there is no statistically significant difference between the SN TAVR and SAVR. Even TAVR shows superiority than the SAVR. This is the important landmark date, the August 16, 2019. The FDA approved TAVR in low risk patient. On that day, from that day, we can use the TAVR as like a SAVR in most of the cases which is not in rheumatic or less than 60 years of age. Even the bicuspid valve in our subcontinent, around 25 to 40% patients are having bicuspid valve, and though the bicuspid valve is offline of level indication, but it is randomly using in our subcontinent throughout the world. What is the how it is improving? Because now the TAVR with local anesthesia and light sedation, it is transfemoral most of the cases, pre-closure device, T on demand, and ICU less than 24 hours. We do not use general anesthesia, endotracheal intubation, transesophageal echo, and additional vascular. We don't need it to make it simplified. This is 2019. There's a lot of people inside the cath lab, but now this is the minimalistic transfemoral cath lab is few people inside the cath lab. What the situation in Bangladesh? Total 6 cases done in Bangladesh, 4 cases done by me and my team in NSCBD, 1 case is Dr. Mohammad and his team in United Hospital, and 1 case done Shahabuddin Talukdar and his team in Evercare Hospital. In our experience in NCBD, our 1 case is tricuspid, 2 cases bicuspid, and 1 is valve in valve. This is our experience. The average age is 70 years, and the highest is 80 years, and lowest is 60 years. 2 male, 2 female. Then average mean aortic gradient was 52 millimeter of mercury. Average peak gradient 104 millimeter mercury. Procedural time is 132 minutes, just more than 2 hours. Per procedural aortic gradient, it was 15 average. Post-procedural aortic gradient on day of discharge, we usually discharge the patient on the 3rd day. It was 12 from 100 to it became down to 12. Hospital stay was 7 days. Post-procedural usually 3 to 5 days. Our complication, there is no vascular complication, and we did the proglide closure. Paravalvular leak is mild, is 1 in non-significant, PPM nil, TIA 1, deserving CBD nil, no death, symptomatic improvement. Shortness of breath improved in all the cases. Post-procedural aortic gradient in 1 month, 10, and post-procedural aortic gradient and 3rd month is just 10. We do the CT scan. This is the it is cold lab data to see the aortic valve. This is our first case. This is the first case, 60 years bicuspid aortic valve is the final shot. This is the 80 years tricuspid valve is the final shot. This is 65 years bicuspid aortic valve is the final shot. And this is our last cases we did in the last month is 74 years in valve. So expansion of future TAVR, a paradigm shift of the treatment of the AS. In 2022, TAVR was conceived for the patient who are not optimal candidate for SAVR, but in 2022, SAVR is indicated in patients who are not optimal candidate to the TAVR. It is the NICVD TAVR team. Thank you very much for patience hearing.